Okay, so this is kind of funny. When I first brought this out, you guys will see the ortho residents may or may not know anything about this. I don't know. We'll see. It'll be interesting. So digital treatment planning and execution. Of course, they're going to know about that. That's kind of like probably, hopefully, a lot of what you guys are learning about in this day and age, since that's the direction that orthodontics is going. But at the time I put this together, which was probably around that same time, 2016 or so, this was like more of a novel concept. There wasn't like as many people doing it. And this was a system that I don't really think is commercially available anymore. But the concept, behind digital orthodontics is that you take a scan of the teeth and you set up your final occlusion. So he had mentioned that with his Brius case, the patient wasn't very motivated. So he's like, hey, let me show you what your teeth are going to look like before, like even though they don't look like that now, and, hopefully give them some motivation to be able to pursue and carry on. So the way that that's done is you just transfer their teeth into a digital intraoral scan. And once you have a digital intraoral scan, you can move the teeth digitally, right? So the way that most of these systems work is that you straighten the teeth digitally. So you put them where you want them to go. Now, currently, we even have the ability to add the roots to the setups, which is surprisingly helpful. Not surprisingly helpful, I guess, but like you would think that you would be able to see where you want the teeth just by looking at the crowns. Because after all, when you're doing an orthodontic treatment case, you are only looking at the crowns, right? You're looking in their mouth and you're seeing where things are. But if you've ever done comprehensive ortho, then when you get to your pano plan repo, you look in the mouth, and you're like, oh, that looks pretty good. And then you look at the pano and you're like, oh, wow, like that's interesting. You got one root going this way, one root going the other way. So having the ability to use roots in the setup actually helps a lot. You can see here at the time we didn't have that ability, but we did have the ability to set the crowns up. So what happens is you see where you want those teeth to go in their final positions, and then basically you reverse engineer that. So you have where the teeth are starting, you have where they're finishing, and then what they do is they basically the software puts the brackets on the finished straightened teeth where they would be if you had a straight wire in it. And then everything is reverse engineered in order to go back to where the teeth are in their current positions and place those brackets in the same place. And in theory, when you put a wire in there, it's going to straighten out and everything's going to be good. Now, some of the things, so this system was actually really, really good in theory. In addition to placing the brackets in the right spot, this system would actually calculate and create custom torques and custom bases. So the way that it would work is that they would actually have a bracket base. So this part of the pad, like right here, that base part, that flat part that touches the tooth, those were separate pieces. And so those pieces would be, they'd have a piece for every single tooth, and then the bracket part of it that was here, they would actually laser weld onto that base at the specific torque that was needed for that tooth. So essentially it was 100% customized, meaning that this wasn't just like a prescription, like, oh, my upper anteriors have 10 degrees torque or whatever. Like every single torque tip, anything that you put into the bracket was basically recreated by allowing this part of the bracket up here at basically the bracket portion to be welded to the base portion. So it was basically the first of its kind. Now, unfortunately, the only system they really allowed you to use this on was the Damon system. And at the time, the Damon system was a little bit more difficult to finish in than it is now due to bigger slots and some other things. So I did about 30 of these cases. And when I debonded my last one, it was like, hallelujah, like I'm never doing that again. And the reason was that, we got our initial alignment, bite seating, all that was great. But there was a couple big problems. So one is that these tubes in the back, you can kind of see how long they are. They created a long lever, basically, so they would break off all the time. And then two, when you got to the fine details of rotation, because the slot was so big and there was nothing really holding it in the slot except for some elastics, rotations were really hard to work out. So it was kind of a novel concept. It was really cool. You had these jigs. You could cut these jigs. If a bracket came off, you could put it back on. But practically, it was a little bit difficult. But it did allow us, this is my niece actually, that we treated her case. I think we got through her case in a little bit under a year, slight class 2. She wore some elastics. And when you look at where the setup was designed to be and where it actually finished, I mean, it is very, very accurate. So the newest kind of kid on the block when it comes to this kind of treatment as far as complete customization is called Light Force. And basically, it's the same exact concept, except instead of using metal brackets, they use ceramic brackets. And those ceramic brackets are 3D printed. And so they're stronger. Now there's some challenges with ceramic as well, right? They're harder. You can wear down teeth if you're not careful. You have to have bite ramps, things like that. But it's the same exact concept. So my youngest daughter is actually in Light Force treatment now, but we'll see how that pans out. But yes, that's 10 years ago is what that looked like. What's that? Oh, that first one was Insignia.
Oh, Insignia, okay.
Yeah. So Insignia, did anybody ever hear of that or use? Did you guys?
Yeah,
is that?
we had a few of those. They come with a wire
Yeah, so yeah, that's a good point. Yeah, so any of the final in and outs that was needed that couldn't be attained by the bracket alone, they would put in the wires, and they would have a custom arch form as well. So instead of having like a stock, rounded arch form, that the arch form would actually be customized dependent on the patient's anatomy and whatnot. So yeah, kind of a cool concept. We were talking a little bit about lingual, and so this was a case that patient wanted lingual. Now in hindsight, I would actually have treatment planned this case a lot differently, just because I look at different things now than I did then. But just for everybody's sake, we all look at smiles. Like when you look at this smile, like what stands out to you? Like what are you thinking? Like, oh, this could be better, this could be worse. Like what stands out to you when you look at the smile? Okay, it's reversed, meaning that like when you look, from the back to the front, you kind of have this reverse smile arc, right? It kind of follows the lip to here, and then it sort of goes up, and then it kind of comes down. So we're a little bit deficient in smile display. We don't, the lip at rest is probably a little bit insufficient as well, right? If you had to guess, because when she smiles even fully, she's only showing about half of her teeth. But this was, at the time, this was Incognito, and I believe that their processes are similar to how they are now. But you take an intraoral scan, same idea. You section that out, and basically the lab will give you a setup. And again, at the time, they didn't have roots. I'm pretty sure they all have root integration now, which is nice. But you can see that they've set it up. They brought those incisors down a little bit. A couple things stand out to me now. I mean, look at the size differentials between the laterals. Like that's definitely something that I would have been talking to the patient about. You can see how the left lateral is a little bit skinnier and definitely shorter than or her right lateral, sorry, is shorter than her left lateral. Her centrals are a little bit maybe small compared to the rest of the canines there. And so definitely some aesthetic options there as far as like, bonding or not bonding. So we'll definitely cover that with them. But these were the Incognito brackets. So they create these trays, and these are made out of gold. And I don't know, I guess, the gold bonding properties was supposedly the best at its time. This was like one of the original, the OG players in the lingual orthodontic space was Incognito. And for years, they were kind of like the only system that people were using that were actually, if you got good at it, you could get good results predictably. And you could finish cases, you could, do detail wires and things like that. It was kind of like the big player on the block. And there was a lot of other ones that came around and then came and went. American Harmony was one that was like around for a while. It's supposed to be self-ligating. It kind of crashed. But, they work, right? I mean, you have these setups and the patient does what they're supposed to. You can see, like I was talking about, flossing is kind of a nightmare. But she wore them. She loved having them behind her teeth. You can see just by leveling, we did get a little bit more in size of display, but that's definitely something that I would have had a longer conversation about. If we could have increased her smile display another, 2 or 3 millimeters, that would have been a really nice change if that's something that she wanted. So this is where we finished. You can see we didn't level out completely on the upper arch. Definitely still a little bit deficient in the incisor display area. But yeah, I mean, it was, she was happy with the result, and she ended up moving shortly after that, so we had to get her finished up. But definitely a little bit less noticeable, even than aligners. What excites me is with the aligners coming out. So one of the biggest challenges with aligners is the aesthetics, right? If people couldn't really see them, then aligners would be like what everybody would want. The challenge is that people do see your aligners, right? You have to put attachments on teeth, and then people see them. So the 3D printed aligners that are coming out now, that's what I'm most optimistic about, because it allows you to change the property of the aligners in very specific spots of the aligner itself. So like traditional clear aligner therapy, you have a suck down, right? So you're limited in force by the anatomy of the teeth, by the suck down, where that's placed on the machine, depending on if you're doing them in-house versus sending them out, the thickness of the material, how long the tooth is, how deep the undercuts are. So for instance, when you do a suck down on a model, if there's a deep undercut, that area of aligner material is going to be thinner than other areas that don't have to stretch so much, if that makes sense. And so there's a lot of variability even in just anatomy, and that's one of the reasons why it's so challenging to predictably finish aligner cases like with one system without any customization. So with 3D printing, you can actually print the thicknesses in any part that you want to make the forces hypothetically ideal. The other cool thing about 3D aligner materials is that they are thermoactive, meaning that when you put them in boiling water, they're restored to their original shape. So when we put an aligner in our mouth that is not fitting in our mouth, meaning that we've reset a tooth, we want to move something, right? When you put it in there, the aligner's not going to fit to some degree. It's going to put pressure somewhere. That's what it's supposed to do. But as it puts pressure somewhere on the tooth and the tooth moves, there's also some level of deformation of the aligner itself with any aligner system that you use. And so they talk about using multi-thickness materials and different things like that to restore, make the material more resilient, make it more like a night tie wire to where it bounces back. But in all honesty, there's no material out there that's a thermoform material that you can truly restore to 100%. So they make up for those insufficiencies by, creating less movements per stage and a number of other ways that you can, make the aligner thicker so that it has more force up above and less rebound. But with the 3D printed materials, all you have to do is put that aligner in boiling water for 2 to 3 minutes, and it's restored to its original shape and composition. Well, now you let it cool down, it hardens up, you put it back in your mouth, now you have that fresh aligner again. And additionally, you can engage the undercuts completely, because before, if you have all the attachments on the teeth and you engage the undercuts completely, you're not going to be able to get the aligner off, and there's nothing you can do about it because it's not really thermoactive at all. But if you have a thermoactive material, then what happens is, if the aligner's too tight, you engage too many of the undercuts and they can't get it off, then you just rinse your mouth with warm water, and that warm water makes the aligner flimsier, basically, and allows you to get it off. And so you can actually engage more of the undercuts of the teeth without sacrificing the movement of the teeth and without creating a scenario where they can't get it off their teeth. And so this is kind of like, there's 2 materials out there right now that you can do that with. One's called Graphy and another one's called Lux Creo. Do you guys have experience with either of those ortho resins? Do you guys get to play with those at all? Okay. Yeah, so between the two, my thoughts are the Lux Creo one's probably going to be the one that comes out on top in the end, just because, at least the current formulations, because it allows you to produce a little bit more force. One of the challenges with these 3D printed materials historically is that they can't create enough force to actually get the teeth to move, and so basically with the Lux Creo material, without being so thick, right? You don't want a material that's 3 millimeters thick, right? No one's going to be able to wear that. But now the materials have gotten to the point where they're a little bit stronger. So the Lux Creo material, in my experience, is a little bit firmer. So you can probably get a little bit more movement with that. But we're still in its infancy there. All right. I want to go over with you guys, and I don't think I've shown either of you guys this case yet, but this is kind of an interesting thing. How many of you are familiar with resin infiltration or have done anything with it? Okay, 1, 2, a few of you guys. So is this the material that you have used before? Have you guys heard of this material? All right. What's been your experience with it? Yeah, really time consuming. Yeah, and that's, at the end of the day, like when I first started practicing, like I went to a number of different dental offices and like showed them like what it was and how to use it, because I thought it'd be awesome to have somebody in town that was like doing it well, enjoyed doing it. And I probably literally went to like 3 or 4 offices, in their office, helped them treat a patient, and then none of them like ever wanted to really do it. So, which is kind of unfortunate because it's a really cool technique, but basically, whether it's orthodontic type white spots, decal on the gingival margins, or in a case like this was more like a developmental hypocalcification. And these types of cases, I would say that it's the least predictable in. But you can see she also had a little bit of decal here on this incisal edge here, which we'll see more later. But the theory behind this material is basically that you remove the basically, let's say, fluoride-rich layer or calcium-rich layer of enamel at a microscopic level on the facial of the teeth, which allows penetration and infiltration of small materials, like alcohol being one of them, which you'll see, and then an unfilled resin being another one. So the idea is you kind of like make the tooth a little bit more porous, and then that allows you to get more internally into the teeth where these lesions reside underneath that harder outer layer, and then be able to fill that with an unfilled resin. So you can't fill it with a filled resin because anything filled has a larger particle size, and it's not going to be able to get into the tooth. So liquid resin monomers, like very, very small molecules, right? So those can travel into places of the tooth where more traditional filled type of flowables or packable composites can't. So what you do is you isolate. This is a gel barrier here. This is just drying off the teeth. So you can see, as most of these developmental white spots go, the more desiccated they are, the more that you see them. Which tells you what? What does that tell you, the fact that it changes color? Yeah, and why do you say that? Right, so I mean, air's getting in there, right? So even without etching or preparing the tooth at all, you know that air is getting into the tooth to some level, which causes, basically as the saliva dries away, the saliva is getting in there. So air's getting in there, saliva is getting in there, right? So that's good. So the more they react to being dried off, the more likely they are to be able to be treated out successfully. So this is a hydrochloric acid etch, right? So normally we use a phosphoric acid, right, which is less strength. I think hydrochloric acid is maybe like 3 times as strong, something like that. So it's a stronger etch. So essentially this is almost a form of microabrasion. And when I was treating a lot of these cases, I would actually use a dry pumice slurry mixed with this etch in order to basically do microabrasion. Now, we're never going to numb these patients because if they're starting to feel sensitivity, we want to know that. But there's quite a bit of microabrasion you can do without having or causing any type of sensitivity. So you can see here, now that we've done that initial hydrochloric acid, microabrasion etch, you can see those lesions even more, which again is a good sign. It means that we're accessing a deeper portion of the tooth. Then what you do is you place an alcohol onto the tooth. And what the alcohol does is the alcohol monomer is like even thinner than our monomer is going to be, right? This is going to travel into the depths of the tooth, and you're going to get a little bit of a preview of what your infiltration is going to look like. So you can see here that we still haven't really accessed this white spot here. We haven't accessed this one here. We haven't accessed these. And so you can kind of look at the tooth and say, hey, am I ready to infiltrate this or not? Do I want to do maybe a little bit more etching like in this area here where I can still see these white spots or not? And so what we typically do is we go back and forth, etch, alcohol preview, etch, alcohol preview, etch, alcohol preview, until you get to the point where, one, either everything looks good when you do your alcohol preview, there's no white spots you can see, or two, you're not really seeing any improvement. You did a whole round of etching, and this looks exactly the same, meaning that you're probably not going to be able to access that. You're not going to be able to go deep enough to access it, so you're going to just leave it. All right, so after you access as much as you can, then you'll actually infiltrate it. And you can see here, this was the area that we didn't feel like we were going to be able to access, so we just left that. You can see here there's some deeper areas as well. But overall, you can see that as we place the monomer on there, it's filled in the teeth pretty well. So this was the before and after smiling photos here. Also worth noting, because it's an unfilled resin, all right, what happens when you shine a light on it? Curing light. Besides it cures. What's that? Yeah, it shrinks significantly. Like a lot more than you would expect, right? So even our packable composites and our highly filled composites, there's some level of shrinkage, right? And so, that's why we cure in layers. That's why we do all the things that we're supposed to do with composite to minimize the effect of the shrinkage. Now, when there's zero fill at all, you have an exaggerated amount of shrinkage. So that's why in their protocol, after you do your initial infiltration with the resin and you cure it, you do a second resin infiltration so that can go into all those areas, hypothetically, that have had that shrinkage, and it can seal those off as well. So you don't want to forget that step so that it'll last. All right, so let's look at a few cases now. Most of these cases don't have imaging, but then I'm going to show you a couple that do. And I just want you, what we're going to do is we're going to go through what we see without the imaging, and we're going to try to hone in our skills of what we can diagnose or not diagnose based off just the clinical photos, okay? So look at this patient here, and somebody start diagnosing this case. What are you seeing? Let's generate a problem list. Okay, posterior crossbite, unilateral, bilateral. Okay, bilateral posterior crossbite. Okay, so when we see a crossbite in general, all right, we all know what that is. We said the word, we know what a bilateral crossbite is. But what are some of the things that start going through your mind, conversations that you want to start having with the parent and the patient about a crossbite? What's the relevance? Why do they want to care? Why should they care? Why do you care? You can just... Okay, so the crossbite could indicate a narrow upper jaw. Most of the time it does indicate a narrow upper jaw. And as Dr. Hill mentioned, if they have a narrow upper jaw, there's other things that could be complicated by that. It could have an effect on the airway, right? And I know there's debate about, airway and what affects what, but there definitely could have an effect on the airway. So that's something that could be important, right? What else? Crossbite. What are you talking about? Like, you tell the parent, oh, your kid's got a crossbite, let's fix it. They say, why? What do you tell them? Okay, what about function and stability? Okay, so what about, let's go there. What about CRCO? Well, let me ask you this. Do you think this patient has a CRCO shift? Why not? Okay, so I agree that more often, like if you have a bilateral crossbite, you're less likely to have a shift than a unilateral crossbite. Agree? Okay? But keep looking. Do you think this patient either has or had a shift, and why? How much is it off? Can't find. Oh, where's my mouse is being crazy. Yeah, it's 2 to 3 millimeters off to her left side, correct? Let's see. Where's my mouse? Can't. There it is. Come here, buddy. Right there. Here we go. So you can see the lower dental midline is about 2 to 3 millimeters off to her left side, right? You also see that the crossbite is more complete on the left side than the right side, right? Look at the facial rest photo. Do you see anything in the facial rest photo as far as symmetry goes? Yeah, maybe off to the left a little bit. So my question is, do you hope that this patient has a CRCO slide? Got some head shakes, yes. Why do you hope that they have a slide? Right, that means that once we correct the crossbite, they're going to shift back, right? And the midline will be closer to on. Now, chances are, I think this patient is over like 9 years old. Chances are that that whole midline shift is not a slide, right? There's probably a component of this shift that is the actual mandible growing asymmetrically to the left side, okay? More likely than not. Now, you won't know that until you check for a shift and or until you treat them, but we'll see what things look like after we treat this patient, okay? So now we've identified that one important reason that the crossbite, or actually two important reasons. One is that there could be potential small maxilla airway issues. Two is that there could be a negative effect on the growth, all right, causing that lower jaw to shift to one side, causing a facial asymmetry, okay? Why else? All right, I don't really care about either of those things. My child sleeps fine, and like I think she looks great. What are you talking about? Her chin's not off. So why else? Why does the parent care? Is that it? They don't care anymore? We're good? Just leave her? Nothing? What's that? Okay, so tell me more about that. What happens functionally when you have a crossbite more often than when you don't have a crossbite? Yeah, you can cause occlusal wear, you can cause cracking, you can cause chipping. And now, yes, these things are all things that you can monitor for. And in this specific case, we're not seeing a lot of dental destruction yet, but this patient is still pretty young. So that's definitely something that you'll want to have a conversation about. You want to talk to the parent. You want to educate them about that. Hey, you know, like looking at where things are, another thing that can happen because the teeth don't really fit together right, especially if they do have a shift remaining still, right? Their CR is not going to really be fitting at all. They're going to be hitting edge to edge somewhere. Right? They're at a higher risk of wearing down, fracturing, or breaking these teeth. And she has permanent teeth in her mouth right now. So that's definitely a conversation that you'll want to have. Now, going back to our potential airway problems or not, all right, what else do you see, or is there anything else that you see on here that would make you more or less suspicious that there might be something like that going on?
By the way, when I say airway, I don't give, well, I think there's a lot of stuffy noses and irritation and inflammation up there where they can't breathe through their nose and close their mouth when they sleep. This whole stuff about, you know, from where we image down is a whole different animal.
Sure.
Which is not necessarily our thing that we do or look at or diagnose. But
sure, yeah.
A fair amount here where kids look, you know, mouth breathers or they're just, you know, stuffed up. But then they're coming out in the correct posture when they sleep.
Right.
So go ahead. Sorry.
Yeah, if they're mouth breathing, I mean, you know, ideally we want our patients nasal breathing, right? They're going to sleep better, they're going to have better oxygenation, they're going to grow better. So, you know, is the upper jaw contributing to her lack of ability to nasal breathe at night? We don't know. I mean, looking at the photos, does anything else stand out to you that may raise your red flags a little bit like, oh, maybe we should ask more questions about sleep?
She's got a retrograde mandible.
Okay, so there's a little bit of a slight downward, backward growth pattern, right? Now, she's not like excessively vertical, right? I mean, you can see that the lower third of the face is not, you know, increased too terribly much, but she definitely is a little bit retrognathic. So that, yeah, there's definitely an association between that, a shorter chin, throat, neck length. What about in this photo here? Anything else you see in this photo here? Maybe even a little bit in this one here? Like, does anything stand out to you? Like look underneath her eyes. Like, does that look like normal to you? Like, if you look at that kid, you're like, oh yeah, that's like probably like completely normal, like the red, the little shinies. Like, have you ever, you know, you've heard the term allergic shiners, right? Now, is this due to her small upper jaw? I have no idea, right? It could be allergies. That's why they call them allergic shiners, right? But when you start to see things, you also, if you look really closely, you can see, although we don't have scleral show, I mean, the lower portion of the eye is a little bit, the lower eyelid is a little bit lower in this patient. So again, none of these things are definitive or like, hey, I'm going to diagnose this. You're never going to diagnose a kid with sleep apnea unless you go to medical school and become a sleep physician, right? But these are all little things that you want to put in the back of your mind to make sure that you're asking the appropriate questions, right? So when I see, things like this, you can see, the mid-face a little bit weak in the cheekbones here, retrognathic mandible. There's a lot of things that say, okay, is this child sleeping and growing like they should be? Well, let's ask some questions. Let's find out, okay? Do a pediatric sleep questionnaire, and if warranted, send them out for a sleep study, all right? Get evaluation further, because this stuff goes undetected all the time, right? And it's not something that you can really catch up on. Although it's true that some patients do grow out of sleep disorder breathing symptoms, they self-correct over time, let's say, meaning that they have sleep disorder breathing, and then as they get older, for whatever reason, maybe tonsils adenoids shrink, maybe it's just growth, they outgrow that, and without intervention, that is true, that happens. But that doesn't go back and reverse any of the damage, so to speak, that's been done while they had the disorder, if that makes sense. So when you have sleep disorder breathing, you're not growing as well as you could be. And if you look at the studies, your brain is not functioning at the level that it should be. So as far as academic performance in school, test scores, all of those things. All right. So if there's a problem now that goes missed because no one ever asked the questions, then that's something that you can't necessarily get back later, if that makes sense. And so it's important to ask the questions, right? Point them in the right direction. All right. What other diagnoses? We talked a little bit about the retrognathic part of the lower jaw. And we talked, well, tell me about the depth of bite. What do you see here? Is this an increased depth of bite, or is it a deep bite or an open bite? Yeah, more of a deep bite. Okay, so what do you always want to associate with deep bite? You have a deep bite, you hear deep bite. What do you always want to check when you hear deep bite? Check for. This is another one of those things that often goes missed. And if you miss it until phase 2, you will be working with, a lot of times, a more compromised result. Okay? So deep bite, what's very closely associated with deep bite? Irreparable damage that can happen with deep bite, and does on a lot of deep bite cases. What is it? Attrition of what specifically? Yes, lower incisor attrition. So as soon as you see a deep bite, you want to be checking the lower incisal edges and seeing if those are worn down or not. Now you can see here, even from the occlusal view, you can actually still see some of the mamelons in the middle. So this specific case doesn't have a ton of incisal wear. We currently take photos with the bite open, which I think is a good idea, so you can document it from the frontal view, which is probably the more important view to be able to see incisal wear. But in this case, we didn't. So that's something that you always want to check. If those incisors are worn, you want to let the parent know about it. Because if they don't do anything about it, then that will get worse, all right? And by the time that they come in for phase 2, they might have worn them down to the point where even after you straighten them, the edges are going to be uneven, and or the incisors are going to look short if you have to E-plasty or something like that. Okay, so talk to me about crowding, dental crowding in this case. So is this case, mild, moderate, severe crowding? When you look at this, like, what are you worried about? What are you not worried about? How do you kind of determine, without the x-ray, without 3D imaging, what kind of gives you a ballpark of how dentally crowded this patient's going to be and what issues they might face? What's that? Mild crowding, okay? So when we break this down, so we can look at the incisors, right? We have the front 4 incisors here, all right? So would you agree that most of the crowding in the upper arch is currently manifesting itself in the incisors region? Is that a fair statement? Okay, yeah. So when you look back here, you have basically from canine to second primary molar, you haven't lost any teeth, and there's not crowding of those teeth per se. And typically, if you have canine first molar, second molar, there's enough space for the permanent 3 teeth that will replace those, the 2 premolar, assuming that you don't lose that space, okay? And then on the lower, we have a similar situation, right? We have canine to second molar on both sides. We haven't lost any. And we have a mild amount of crowding in the front. So if you had to put a millimeter's worth of crowding on this upper arch, how many would you say and why? Anybody? One, 2, 0. Okay, someone make the argument for 0. I'm not saying that that's wrong. I want to hear the argument for 0. Well, but we talked about the leeway space being used for the permanent successors, right? Because the permanent canine is going to be larger than the primary canine. This is going to be about a wash, and then this will be a little bit bigger holding space. So, you know, let's stay in this region here. Let's just assume that this is all good, and we don't really have any extra space for the incisors. So make the argument for 0.
You have a little rotation of the upper left incisor. You have a little bit of space between the ones, and then it looks like a little bit of space between the right.
Okay, so you're saying basically based on the available space that we have that it'll be a wash.
Yeah.
Okay, make another argument for 0. I mean, I'll buy that. That is true. There's some spacing there that you can use. But there's another argument to be made for closer to 0 crowding.
I mean, you're going to do an expander, right? So
Well, I don't know. I mean, we're talking about dental crowding now, right? We got to justify what we're going to do, right? So, I mean, like, we're having a hard time justifying it based off crowding, right? And in some ways, we're having, even a debatable time justifying it based off some of the other things, right? Because she doesn't have teeth wear, right, yet, right? She didn't fracture anything down, right? So we have to think about, the CRCO slide, the growth thing. Yeah, that's a pretty good justification, right? Most parents are going to want to correct that. But based on crowding alone, what's another reason why this particular, and I haven't showed you a Ceph yet, that's your clue. And I'm not going to show you a Ceph, but what's that? Yeah, she's upright. Those incisors are retroclined, right? Where are those going to end up? They're going to end up more proclined than they are now. As you procline, those teeth are going to have space. So from a dental standpoint, and pretty much the same argument can be made here, although I would say that we have a little bit less ability to procline these lower incisors than we do the upper incisors. But you'll have some proclination there as well. So from a dental standpoint, as far as like impacted teeth, root resorption, having to pull permanent teeth, we can't really justify the expansion there. So we talked about justifying the expansion based on preventing unwanted growth of the mandible, right? Having that lower jaw move over to one side or the other. Nobody wants that. What other reasons can we justify expansion in this case? Well, we also mentioned that there is a potential for destruction of the teeth in the posterior. We agree, like that's potentially there. Yeah, it hasn't happened yet, but that could happen. What other justification do we have? And or, if this were your child, why else would you want to expand? All right, in addition to those two things we already mentioned. Okay, so you'll open the bite up. So depth of bite. So as you expand, you will open the bite up, at least temporarily. So that could help, at least in the short term. Why else? Okay, so you bring it down and forward a bit. Now, does it need to come, well, it needs to come forward. We mentioned that, right? Does it really need to come down that much? I mean, you could afford it to come down a little bit. I mean, when she smiles, she has, incisor display, a little bit of gingival display. It's definitely not going to hurt. But what else about what you see is going to be different after you expand? Yeah, I mean, look at the smile itself. I mean, you can see those buccal corridors, basically, you can see how narrow the smile appears just from a purely aesthetic standpoint. So is that a justification? It would be for me and my kid, right? It's a conversation to have with the patient and parent. Is that important to them, right? This is the whole theory of informed consent. We go over what would be different, why you would do something or wouldn't do something if it were your own kid, and then you let the patient make the decision. Now, as you guys alluded to, this patient did decide to do expansion, and actually this patient was almost 10 years old. So we did an expander, and then we did a Holly. All right, so this is what things look like after expander and Holly. Okay, so you can see that the incisors on the upper and the lower kind of worked out a little bit just by having the expansion, having the room. And you can see that the lower incisors, again, not completely, they're still overlapped a little bit, but all the rest of the permanent teeth have come in. All right. Now at this point, and you can see that the smile is a little bit more broad, although you can see we actually still have room within the jaw to expand this arch form dentally. You can also see that there's still a little bit more of a, let's just call it V shape to the maxilla, even though the jaw itself is more U-shaped. The teeth and the dentition where they are at this moment is more V-shaped. So you're in a situation here. Now, does the patient need to have a phase 2? Not necessarily. All right, let me ask you another question. Did that patient have asymmetric growth? Do you think? Or were they shifting? Yeah, I mean, we're really, really close to having a perfectly on midline, which tells us that, in all likelihood, that patient was shifting. Now, again, in my opinion, this is the exception, not the rule. Most of the time, when a midline is that far off, and I'm assuming that that midline's been off since she was 6, so that's almost 4 years of, 6 meaning when those molars came in, all right? So that's almost, and maybe even before that, because the primary teeth were in crossbite as well. But at least from 6 to almost 10, almost 4 years, that patient was in a crossbite, a functional crossbite, and presumably had a pretty big CR-CO shift. But in this case, one of two things happened. Either A, it grew back the other way once the occlusion was corrected, or B, and probably more likely, is that once we got her off of her own teeth, the jaw just relaxed back into place, and the asymmetric growth had not occurred. So again, most of the time, I would say this does not happen. But this patient got lucky. Again, most of the time you have wear of the teeth. This patient didn't have wear on their teeth. So pretty much she's just lucky. So that's what I would tell her at this point. Is like, you're lucky. You don't have to do anything. If you want to do something, you can. But she wanted to have a more broad smile. She wanted to have everything corrected. So we ended up doing some braces and getting everything finished up. You can see, well, actually, what can you see? What's one thing that what's one sort of consequence of this treatment? Long-term negative. And not necessarily the treatment. I mean, maybe if we would have gotten in earlier, we'd have had more room and would have been less likely to happen. But what are you seeing here that you don't like? Long-term. Yeah. So you look down here, you can see, again, this was the area that was crowded. So we back up here, right? I mean, so you can see that these teeth were crowded. And you know, that's one of the things that we have to be careful about whenever we treat an orthodontic case, right? That you avoid moving those roots facially. Now, this is actually one of the things that I feel like is one of the biggest benefits of customized treatment, right? So when you go, so this case was treated without any sort of customization, right? I mean, it was like old school, like plaster models, and we did indirect bonding method with plaster models. We had no idea how good our bracket position was until we put wires in and saw what it did afterwards, okay? So we also have a standard prescription, right? So in a case like this, where you know that there's going to be a higher likelihood, something you see on the x-ray, the root's already forward, you could actually program in, more lingual root torque on that tooth or all of the anterior teeth in order to get the roots back into the bone where you want them. So that's something that I think you're going to see more and more of, the more customization that we're able to do. All right, next case here. So.
I like this kid already. Yeah, yank him out of the pool, give him off Call of Duty. Let's go.
Yeah, exactly, right? He's probably not concerned at all about anything about his bite. So what do you guys see here? Let's diagnose this case. All right, what do you see here? Let's make our, what's that? Okay, anterior partial or complete crossbite? Okay, anterior partial crossbite. All right, what else? Posterior, what kind of crossbite? Posterior unilateral crossbite, complete or partial? All right, so complete left posterior crossbite, partial anterior crossbite. All right, so what did we talk about? What's the significance of that? We just mentioned them all, right? Let's talk about growth. All right, so what's the significant from a growth standpoint? First off, so do we think that this patient has had asymmetric growth? Do we think that they're sliding, or do we have no idea? Yeah, we got a nice. So where is that lower jaw? Is the lower jaw to the right, to the left, right on? What's that? It looks a little bit to the patient's right this way. So is that good or bad? Where's the lower dental midline? What's that? The other way, right? Like kind of like way left, right? Like half of a tooth left almost. Okay. And does that add up with our crossbite? Does that make sense that it would be left? It does, right? You have a left crossbite. It's probably going to shift to the left, right? So this adds up and makes sense. Are we hoping for a shift in slide eccentric here? Yeah, we're hoping for a slide, right? If they have a slide, then when we correct it, they're going to move back. Now, doesn't really help. If it's hard to tell where the chin is. If that chin is in fact off to the right, I think that the photo might be a little bit, I think it's actually off to the left a little bit. Do you see the right part of the chin is lower than the left part of the chin? So when I'm looking at this, I think that, although his face kind of masks a little bit, I think his chin actually is a little bit off to his left, with that right side being longer. Now, if you had a pano or a cone beam, you could actually measure the length from the condyle to the angle of the mandible, and you could see which one's longer from right side to left side. And that's, again, one more thing that will help you determine has asymmetric growth occurred or not. But at the end of the day, I want to make sure that this kid, hopefully shifts back over and his midlines are closer to on by whatever we decide to do. Now, talking about, so justification, possible growth implications, all right? So that's one reason we justify the expander. Can we justify this case based on crowding, dental crowding? Like, would you expand this case if eliminate all three of these bottom photos? Like, you can't see them. You know what I mean? Like, are you going to, well, you can't see that one either, all right? All you got is these, all right? So are you gonna expand based on just those two photos, which basically what I'm saying is due to dental crowding only. Is there a justification to expand this patient? Not really, right? Especially without seeing any sort of pano or ceph to know like what's happening with the permanent teeth that are erupting. But overall, seems like he has about enough room at least for the teeth to come in, right? There's nothing that's overly like, oh, you definitely need to do something, right? So our justification for expansion has to be related to other things. One thing is the potential growth. What other reasons might we justify expansion, and or if this were your kid, right? Why else would you be expanding this patient? Okay, so if this patient had down-forward movement of the maxilla, you're going to have more incisal display. You can see that he's quite deficient when it comes to incisal display. And you're going to have more forward movement of the maxilla. Now, does he need forward movement of the maxilla? I don't know. It's really hard to tell off of extraoral photos, right? We would need the ceph to see the actual, position of A point A and S, all those things. But it's probably not going to hurt anything, right? And if anything, he's got sort of an anterior crossbite tendency, which means he has more of a what type of dental malocclusion? Yeah, he's more class 3, right? So that lower jaw, we're worried about that coming forward too much, right? So the further we get that upper jaw out in front of things, the more likely we are to have a good result, okay? So we did an upper expander, followed up by, at the time, we used a Holly with finger springs, which I would not suggest learning. That's an art that you never need to know, and you won't miss out on anything. So, but at the time, we did a Holly with finger springs. So you can see here, now, was the jaw shifting due to the crossbite? Yeah, so definitely it's probably at least halfway back over from where it started, right? Now, with the expansion, did we, let me see how I ask this. I didn't measure this out, right? At the time, we didn't even have cone beam, right? But do you think that our expansion was primarily skeletal, primarily dental? Yeah, one of those. And why? So we'll go back to here. Then we go to here. Dental. Why do you say dental? He was 7 years old when we expanded. 7 years, 3 months. So why do you say dental? I mean, I'm not saying you're wrong. I just want to know why. What are the arguments that could be made for that more dental changes versus skeletal changes? Meaning, another way to ask that is, what would you expect to see that you didn't see as much if there were more skeletal change? Okay, so true, right? There's that. Now, granted, these time points are quite different, right? I mean, obviously, there's a number of years in between. This is between phase 1 and phase 2. So could the diastema have closed between then? Yes, but it's a good thought, right? Certainly, if you didn't see a diastema at all during your expansion, or that didn't get bigger, you would think, more dental versus skeletal. What else? You guys mentioned what we wanted to achieve by expanding, right? From a facial aesthetic standpoint. So did we achieve that? Or did we achieve that as much as we wanted to? Do you feel like our vertical relationship of the maxilla changed a lot? Not a lot, right? So if I'm looking at this and I don't have anything else to go on, and I'm just looking at, hey, my incisal display before and after, yeah, I mean, it looks like there's maybe a little bit of a change, but certainly nothing to write home about, right? I mean, if I had, let's say I did an MSE on this kid, not saying that I would or that you should. Again, we didn't even measure the jaws to see if, which one, we didn't even say if we need true skeletal expansion or not. But when you're thinking about these cases, like what happened, and sometimes you only have photos to go off of, like that's an argument that maybe it was more teeth than jaws. Now, what's the opposite? What are the arguments that it was more jaws than teeth? Okay, going back to here and going to here. What are the arguments that we did get skeletal expansion? All right? What? Absolutely, right? When you look at these teeth are palatally, basically retroclined, right? Which from a skeletal standpoint is kind of good. That means the jaw's wider, right? So there's kind of arguments that maybe A, we did get a lot of skeletal expansion, or B, aesthetically, we could have gotten more. So without a 3D superimposition, you don't really know, right? If you do one before and after, you can see the exact changes, which was skeletal, which was dental. But these are things that you want to be thinking about when you're looking at your cases, when you're analyzing, what happened, what didn't happen. So when we get to this point here, what are the conversations that we're going to have? What are our goals now? Like, what do we still want to correct? Because does this kid need ortho? Does he need it? I mean, no one needs it, right? No one ever died from crooked teeth, right? But if he's saying, hey, look, like I'm happy with the way my smile looks, are you recommending ortho? If he's happy with the way the smile looks, and he's not complaining about chewing or eating or any kind of functional things.
I mean, if he likes that right canine is kind of up and might not come in all the way, then yeah, I'm doing it. But
I mean, would that come down a little bit more on its own?
a little bit, but it's going to probably be stuck out a little bit.
Maybe stuck out a little bit. But let's assume that he does. He's fine with it. He doesn't. I mean, because you'll have patients I've had patients with pretty messed up smiles that don't really care. Like, I care, but I mean, I don't want to be treating them caring more about their teeth than they do, right? So if we're justifying treatment in this case, why are we doing that? Or are we? Is there a reason to justify it other than aesthetics? Maybe canine guidance, we'll see. You could let that drop in and see. Does he have canine guidance? Does he not? Maybe he's picking up an interference. You can check the function for sure. I would check the function for sure. So if the majority of our justification is not functional in nature, then what are we justifying with this case? What do we want to see? So you mentioned the canine. Yeah, okay, so aesthetics. Okay, so there's crowding, right? All right, so let's say the crowding's gone. Anything else aesthetically? What goals do we have with this case aesthetically? And we talked about this a little bit when we saw way back, his initial photos. All right? So what else do we still want to accomplish with this case? Yeah, we want to improve the incisal display, right? So we want to, hopefully use some sort of mechanics that can bring those teeth down more. So currently when we treat cases like this, one of the things that we'll offer them is tad extrusion of the anterior teeth. So we always start out by using wires to get the teeth down as far as we can, like RCOS wires on the top and on the bottom, and bring those incisors down as far as we can with the wires alone. And then we look and we reevaluate. If that's enough, great. If they still are lacking an incisal display and they want to have a more ideal smile, then we'll talk about placing a tad in the anterior and bringing those teeth down further. So this was before we really did any of that. So we used the wires and we got as best as we could. But looking back at this result, I don't want to say I'm embarrassed. I mean, we did the best that we could when, with what we had at the time. But for me, yeah, the teeth are straight. They're aligned. I mean, the occlusion's good. But when you look at his smile, it's he looks like he's going to look like he's 10, 20 years older than he is his whole life, right? Because we didn't get that true increase in vertical that would have been ideal. His upper jaw still looks small, even though it's probably not. I mean, to your point, yeah, we uprighted those posteriors a little bit, but it doesn't really look like his upper jaw is excessively small. It's just that he's vertically, deficient of the maxilla, right?
You said you placed a tab in the anterior for the extrusion.
Uh-huh. So basically, make sure that you have room between the roots, right? If you need to upright the roots first, then do that. You'll place, and you'll have to sometimes perform a frenectomy, depending on where the frenum is. But you basically pull the lip up, and you're going to put that as pretty much as high up as you can, where the patient can still keep it cleansable. And then what I do is I run a T slot on the wire itself. It's actually, if you look on Pearl's Facebook, you can find, I showed a case on there that shows the exact mechanics, and they referenced an article, which I was unaware of, that did something similar. But basically, you have a T slot here. So the one T goes on the wire this way, and the other T goes this way. And then you place a wire that you bond with composite onto the tad, and then you place an open coil spring here, and then it extrudes, and you move those teeth down as a unit, and then you hold them there for a few months, and then you take it off. One of the things that you'll also want to do mechanically is you'll want to put some reverse curve of speed, or actually some curve of speed into the upper wire. Right? So you're going to put as if it's trying to intrude those anterior teeth. And the reason for that is your TAD mechanics are going to overcome the forces of pretty much any wire that you use, even a stainless steel wire. So when you add curve of speed of the wire, you're placing a force on these canines and premolars to extrude, while you're extruding the anterior teeth, so you don't get a reverse, curve of SPE, like funky looking smile line, and then have to re-level afterwards. So we'll actually place curve of SPE into the wire before we place that in, so that everything kind of extrudes as a unit. And then you also have to know that as those teeth come down, they're going to be basically coming down and back, which is, in a sense, going to put them in more of a class 3 relationship almost, because the lower jaw is kind of like doesn't know what to do. So you'll want to run a light class 3 elastic on both sides as well, which does two things. So let's say you run like a 4-3, 4-3 on both sides. A, it's going to help with that extrusion of the premolars to help keep it up with the anterior teeth. And B, you're going to have a slightly retrusive force on the lower anterior teeth to keep your occlusion good while you're doing that process. But again, like I say, at the time I wasn't even looking at things like that. But this is, if I had the chance to go back and treat this case again, that's what we'd be talking about. All right.